So we're going to move on to the panel discussion, how to move forward, and moderating will be Dr. Nittaya Phanuphak, who is, I'm sure everyone knows very, very well. Do you need an introduction? Not really, no. So over to you. Thank you so much.
Thank you very much. I was assigned a moderator here, but I believe this could be something that is like a more informal platform for all of you here who are still here in this room. I congratulate you to please come forward and then ask questions. And I think that questions that is more on the implementing aspect and experiences that you have had so far. You may have not been in a country or in a hospital where there is like this nationwide S&D assessment and then implementation and then like this baseline inline assessment. But you may have been someone who have already taken some actions to address this and would like to share. I think that would be something that is kind of very practical for us. I also would like to congratulate Vietnam when seeing that huge dramatic change in a positive way with just 9 months of intervention. And I believe that yes, we may need funding when we plan something new. But when the countries see results like this, I think it is very likely that the government, the minister and ministry will be very willing to integrate that into like a routine system. So is there any questions from the floor? If not now, oh yes, please.
Thank you for the...
four first and then microphone too.
All right, I'll go first, uncharacteristically. So I actually want to thank the panel for a really impressive array of and breadth of presentations, and especially Martin and Rena for really heroic work in very challenging situations that are both from a public health and humanistic perspective, enormous challenges, but clearly of deep personal importance and perhaps injury to your life experiences. And so I really congratulate you for getting up in front of this group for doing, to share those experiences. And Bruce and Dr. Do, again, amazing interventions which really seem to not just move the needle, but actually move the boulder in a direction that I think many of us, I came here with aspirations, but with the idea that these are going to be really difficult things, and I actually now think it's actually, these are like 90-90-90. These are attainable things. We just have to think about it. But especially Rena and Bruce and Dr. Do, you actually kind of gave us very successful interventions. I think at least I'll posit that. And so we've heard about success stories. Martin's story was a bit more of a challenge than it was. It's a success in so much of raising a cultural context that I think many of us in the West, although I look like I'm from the East, I'm really from the West. That we're are blind to, and that's really my segue to my question, which is in for panel discussion, right? So I think you showed us the sort of ways that have worked in places that were willing. I want to invert the question because I think it's their blind spots that are it's like the people we're not looking at, the people we're not serving, the populations we're not serving, the countries or regions that we're not serving. And so I want to, with your perspective of, let's call it success, perhaps limited from the global perspective because it's not global. What do we do about the less willing countries from the perspective of health ministries, the less willing from the healthcare facility perspective, the less willing communities embracing key population-led healthcare and so on? What, for just to volley this into for discussion, how do we address that to our colleagues, or even, let's say, places that are not so collegial? What's your advice?
I'm happy to start. Having had to deal with some situations where there have not been open arms to move forward. I think, first of all, most people that I've encountered care that there is stigma. So I want to say that, it's not that people don't care, but they don't really necessarily understand how to do, and they feel like they need extra resources to do. And so I think, so the obvious short-term answer is, well, you give people some money and say, this is what you have to do, they'll do it, right? But that's not sustainable. And so I think it's a matter of a lot of dialogue, and also setting expectations and standards for people. And I do think that one of the sort of subtle benefits of a multi-country experience is that if you participate and you see, and this actually happened in our network, and I will not name names, but one country came to a network meeting and had nothing, and I think they were really embarrassed, and so they're trying to figure out how to move things forward. But I think the other side of that is that the political realities in some countries, whether they are, pure politics or bureaucratic or organizational politics, make it difficult in some countries. And so it takes a lot of time and patience and engaging stakeholders to try to figure out how to move those pieces so that they can then come together and then go forward. It's not easy. I think you knew that, but I think it's a matter of taking the time and the focus to try to really, get things going. So just a few ideas off the top. Yeah. Oh, and one more thing, which is bringing the community directly, and it's the obvious thing, bringing the community directly in the limelight in a way in which there's a demand and there is clear publicity about harm that's being caused. I think also, you don't want it to happen, but when it happens, you need to leverage it and say, look, there are things we can do, there are solutions, they can be put into place.
So I've been scoping for answers around chemsex for the last 2 months, and it appears that there are possibilities. One place is London. So what London has done is different departments now. So the public health through Chelsea and Westminster has already started this amazing clinic, but it's not enough, because the issue is not just about health. The issue is also about social justice, and how do you deal with, for example, the syndication of demand and supply of chems, right? Which we have found to be the case, both in Malaysia and confirmed with the Metropolitan Police in London. So for chemsex itself, I can understand why countries are not dealing with this, because it's huge. It's not small, and for Asian countries you have to really dig deep, because you're talking about sex, you're talking about drugs, and then you're talking about pleasure. Asians don't do those things together, right? Like you can't have a conversation, right? The minute you start putting these things together, then the conversation stops. So what London has done is Her Majesty's Prisons Probation Service is involved, the Metropolitan Police is involved, the Public Health Service is involved, and community groups, different community groups are involved. And with all these involvement, and they deal with really important problems, for example, sexual violence. And it requires an integrated approach that is missing in a lot of our services. But that is London, right? So it takes a lot of money to set up Dean Street. You know, all the swanky pictures that you see, well, it's not cheap. But there are elements to it that people will want to see. And the elements, if you study it, I feel that if you study it, if you boil it down, and you study what the community needs to see, we can do it cheaply. Well, I wouldn't say cheaply, sorry, less expensively. For example, being confidential, right? So at Dean Street, you go in and you key in this thing, your details in a tablet on a screen, and then it prints out your tags, your stickers, and that's it. You go into a room and you do your thing, and everything is shown to you what to do. They are cheaper. It doesn't have to be so swanky. It can be cheaply done, right? As long as you understand that people want confidentiality, as long as you understand that for some people they want to be anonymous, and it's okay to be anonymous. So if we can switch our systems around to really focus on community needs and address those needs, then it's possible. It's not rocket science.
Can I just make a comment? Martin, I think that was what you said is absolutely true, but I wanted to just add 2 points. The first is that another thing that really facilitated all the kind of the emphasis on chems and the recognition of the importance of chems was conversations amongst gay men. So chems for a long time were really underground, and as I'm sure everybody knows, the use of chems is associated with a huge amount of shame. And MSM who were using chems didn't like to disclose to other MSM that they were using chems. And so they were often doing it in little groups, but in silos, full of shame. And one thing that we help to do in our service, we have this amazing man called David Stewart who basically leads on all our chems interventions, created a space where MSM could come together and discuss what was going on and explore the reasons that they were doing this. And they uncovered all sorts of deep things within them to do with all sorts of very complicated areas of their lives. And just being able to speak about those things was the beginning. And it was when they could speak about those things and then people started realizing how big a problem it was that we could then start to address those things in clinic. And that was the start. And then you then start to engage clinical services, public health, and the wider policy makers to then realize that we have to do something about that. The second thing I wanted to say was about resources. So there is this perception that Dean Street is a really rich clinic. And I have to say that Dean Street is a rich clinic because it's in a rich city compared to other cities around the world. So it would be very hard, I think, in many cities in Asia to replicate a Dean Street. But in London, Dean Street did not have any more resources than any other clinics in London. What we have, or what we still have, were people who realize how important the experience of the people who walk through our doors is, how important it is to find out what it is that people need and to find a way to deliver those things. And I think that what Bruce said about systems basically creating the outcomes that they want is so true. And one of the first things that we felt was important was to recognize that we had to create a place that was free of stigma. We had to look at ourselves and say, what is it about a service that prevents people from accessing it? And that would very often mean changing a lot of the things, the structures that we had in place that created those barriers. And those things don't require money. Those things require people who are willing to sit down and speak to the people who attend their services and change things to make them better.
Thank you for the opportunity. I'm from Indonesia. Maybe I want to ask to Dr. Martin. Maybe our conditions is quite similar with your country. Yeah, the stigma is quite strong, especially from the family itself. What I want to know is, do you have any specific polite, maybe ways to change or to change the mind of especially our elderly that has a very conservative mind or concept about everything? Thank you.
So just to understand, is this stigma about HIV or stigma about being gay?
I think being gay and
they're slightly different.
It's different, but it's related. I think to both. Thank you.
Okay, so in our context, the being gay one is a little bit difficult because of religion. Okay, so let's be very clear about that. But when you're approaching, if you're a parent, right, you always want the best for your child. The reason why they become very upset when the children they perceive is doing something wrong is because they think that they're probably going to lose the child, or something bad is going to happen to their child, right? So if you want to reach your parent, and it can only happen from son to, or from a child to the parent, is you need to open the communication. It cannot be opened by the other way, right? Because of our culture. So the child has to learn to talk to them as an adult, not as a child. And that is I suppose, the growing up period, the difficulty of having your parent look at you as an adult, and not somebody that they have to sort of control or to save. If they see that you're living your life in a fashion that is responsible, that you're looking after yourself, and you are a functioning, healthy, contributing person in society, then they're more likely to be more open to talking about all these other things that they're not comfortable talking about. But it has to have that basic well-being first. So I think the best thing that we can do is to live our lives the best we can. And when we do that, I think your parent or our parents will see it as an invitation to accept that whatever they may disagree, and that may never change, but at least they respect the life that you lead. I think that's the best for me anyway.
Okay, thank you for the inputs. But what I want to know is, it is not about me, but I want to know that us as the health providers, how can we approach the parents of a LGBT or that have HIV
well, that's the $1 million question. But we do it with pediatrics, right? So it's not completely different. The thing is, the family is one unit anyway. We don't know how to approach it as one unit because all our education, including the public health approach, doesn't see it. We see individuals only, right? We treat an individual. But in Asia, it's complex because the individual is not alone. And the individual is, whatever the individual does, is linked to a number of people. The question is, how do you link them up without breaking ethics? That's the difficult question. I don't think we need to answer it now, but I think we need to start asking it, the question, so that sometime the answer will come.
And I would like to add that this may sound like theoretic, no, but we have real experience that this could happen, this could work, both in terms of HIV, both in terms of LGBT. So I think this is not something that is like out of reach for us. We have 2 more questions. Microphone number 1 and then number 2.
Hi, I'd like to address this question to Bruce. What was the incentive provided to the participating hospitals to do the survey and actually to act upon the results of the survey? Was there, I mean, I'm thinking about it as how to encourage participant hospitals to join the project.
So the initiative itself, as I mentioned, was funded to work with the ministries, and the ministries recruited the hospitals. So there was a relationship between the Ministry of Health and the hospitals already. And actually, so in Vietnam, Dr. Thuy can, and this was funded through PEPFAR, so that the initial set of hospitals in each country was somehow supported by PEPFAR, although in both Thailand and Laos, they, on their own, decided to expand their network beyond the PEPFAR hospitals. So Thailand scaled up from 12 to 50 some or 60, and Laos involved all of their ART clinics. And there are plans for scale up in Vietnam, beyond the initial group. So, but that's why it's from the ministry, essentially, that really motivates or cajoles the hospitals to join.
Can I ask some related question to that, because I know that these activities has been focused around stigma and discrimination towards PL-HIV, which I think it is very difficult, or it would be like not a very efficient way of doing so if we know that we will have to deal with stigma discrimination towards key populations, or even towards other health conditions within that same healthcare setting. So is there any like evolving idea that this could be more of a broader health stigma and discrimination?
Yeah, so that's a really critical question, and the answer, of course, is yes. I mean, I think again, the way the initiative was funded was circumscribed in a certain way, but I think it's really important to say, I mean, HIV-related stigma, underneath it is K-pop stigma. It's just not being explicitly asked in the questions, but the next step then would be to ask questions specifically, and it's very easy to do. And I would just say, I didn't really, because of time and so forth, we were just talking about this, but Dr. Kringkrai has the method in Thailand. It takes 5 minutes to answer questions on the survey, and it takes them a matter of minutes to program in new questions. So it could be adapted, and I know Vietnam has already asked about, I mean, first of all, it's up to them. It's not up to us. We're not, we're trying to build a capacity, and then they take it and run with it, so they can add questions, and I would encourage them to do so. And I think that's the first next step is key populations, yeah.
Yeah, hi, I'm Don from the Thai Red Cross. I'm a comment more than a question, and this is for Martin. First of all, just to say thank you for excellent talk, but also thank you for bringing up a point that I think is not brought up enough and needs to be more attention to, and that is the stigma within the gay community. And I don't say MSM community because there's no such thing as an MSM community, but there is gay community. In every country in the region, there is a gay community. And I'm a researcher, I'm a healthcare provider, but I'm also a gay man living in Asia. Many friends who are gay Asian men living with HIV in Asia, and for many of them, the biggest source of stigma, or one of the biggest sources, some of them the actual biggest source, is stigma within the gay community. And the number one reason that they're not out about being HIV positive is fear of that stigma. I have no idea what to do about it, but I think just recognizing it's a problem is the first step. And I think we really need to do more work about researching how much stigma is there, what is the source, and how do we address it.
Don, can I ask you, do you think that U equals U is having an impact on that in any way?
I think it's incredibly important, and I really think that it will have an impact, but it's so new, I can't really say if it is yet or not. And particularly, I think, among gay communities in Asian countries where we're just starting to talk about, and because the U equals U is obviously in English and doesn't, that most Asian gay men are not going to understand what that means. But as we translate it, into the local language and start basing educational programs around that, I think that'll be very, very important. And one thing I can say about, I think, Vietnam, because they have K equals K, they're doing it already in Vietnam.
So I just want to say that U equals U just means that nobody needs to disclose anymore. That's the point. That's the importance of U equals U. But what we talk about stigma, especially with HIV, what we found with our community consultations and surveys is the critical point is disclosing to somebody. Disclosing to at least one person that you trust, and you get a positive response. That positive response means everything. And if you disclose early enough before you form your own negative thoughts on top of that, then the less likely you will have, what we call self-stigma, but perceived stigma. You start labeling yourself because mentally you're also discrediting, right? You already think that you have something that is discreditable, and so you're also discrediting ahead of time. So if you can stop that process early enough, then the chances of them living a life that is stigma-free is higher. So it's about empowerment to be able to disclose, having somebody that they can relate to, and getting a positive response is key. So community needs to help, really.
Yeah, it has been a very exciting afternoon, although it's at the end of APACC and a long week for everyone. And I think we should have more time to discuss, but I believe that we will be supported to have this again next year. We have not yet talked much about interventions towards oneself. Which I think we should discuss, which we should have more time to discuss this. So anyway, I would like to thank all the speakers on this panel for their wonderful presentation. And I hope you learned something, be inspired, and started doing something, and probably to come and share what you have, what you'll be doing next year at APACC. Thank you very much. Oh, and yes, please fill in the evaluation form. Thank you. Have a safe trip, everyone, back home. Enjoy Hong Kong for the rest of the day.